Good afternoon and welcome to today's Live with Leadership session. Thanks for joining us this afternoon. A few logistics tips before we get started. We are hoping to be able to answer as many questions as possible this afternoon from participants. To ask a question, please use the Q&A function at the bottom of your screen. If you have any technical related issues, please put those in the chat box and somebody will help you try to troubleshoot those needs. And with that, I will turn the session over to Harold Phillips to begin. Thank you.
Thank you, Anne. Good afternoon, everyone, and welcome to the Office of Infectious Disease and HIV/AIDS Policies Live with Leadership series. My name is Harold Phillips, and I serve as the Chief Operating Officer for the Ending the HIV Epidemic Initiative in the Office of the Assistant Secretary for Health. The Live with Leadership session allows OIDP to share important updates with you about ending the HIV epidemic in the US. And today, I'm very excited to be joined by two figures in HIV research. They're really important and they're doing awesome work. Dr. Nora Volkov and Dr. Dieffenbach of the National Institutes of Health. Dr. Volkov is the director for the National Institute on Drug Abuse, which focuses on the health aspects of drug use and addiction, and is the second largest funder of HIV research at NIH. Dr. Dieffenbach is the director for the Division of AIDS at the National Institutes of Allergy and Infectious Disease. They are NIH's primary funder of HIV research. So for today's session, we will first talk to Dr. Volkov about several issues related to HIV and people who use drugs. And then we'll talk to Dr. Dieffenbach about a recent Ending the HIV Epidemic meeting held at NIH, funded through the Centers for AIDS Research. So, Dr. Volkov, are you ready to kick this off with us and give us some opening remarks and some key points about sort of what has been happening?
Dr. Phillips, I'm absolutely ready. And first of all, thanks very much for having me as part of this very interesting discussion. We've recognized, of course, that drugs have contributed to infection in the HIV epidemic, but most of the attention has focused on injection drug use practices, which certainly is very, very relevant. And as the use of drugs has been increasing in the United States in the past 2 decades, we have seen actually outbreaks resulting from the improper utilization of syringe exchange program, more to say, from the closure of those syringe exchange programs or the lack of support for them that has led to new infections. And this continues to be the case right now in the 21st century, despite the fact that there's a lot of data showing that these programs are effective. But I'll come back to that at the end, because I do want to highlight that in addition to the importance of injection drug use in the HIV epidemics, we have to realize that drugs themselves have pharmacological effects that can increase the risk of getting infected with HIV. And this has become very apparent right now with methamphetamine, as there has been an increase in the use of methamphetamine in our country since 2015, 2016. This has also been associated with an increased association of the use of methamphetamine with infection with HIV. And in fact, currently, the #1 factor contributing to HIV infection in gay and bisexual individuals has been the consumption of methamphetamine. And we understand this because stimulant drugs, for example, activate the sexual drive and motivation of people, while at the same time, during the state of intoxication, these methamphetamine and other stimulant drugs like cocaine interfere with cognitive control processes that are responsible from our prefrontal cortex. So you have this effect of drugs that leads to an intense drive for sexual reward, while at the same time interfering with our ability to control those urges. And interfering also with decision-making, which is one of the drivers that leads to incorrect decisions on how to actually engage or not engage in these behaviors. We have to realize that sex is a reward in our brains, and it's actually the value of that reward is enhanced by the consumption of drugs. It is actually amplified. And therefore, it's not surprising that sexual activities are done many times under the effects of the influence of drugs. And here also we have to recognize that alcohol plays an important role. The other element that is very relevant is that when we are discussing of interventions on prevention of risky behaviors and try to identify individuals that are more vulnerable to engage in risky sexual behaviors, in many instances, they are also the ones that may be more vulnerable to engage in other impulsive behaviors. So there is a concordance that brings together factors of risk that are going to not just increase your vulnerability to take drugs, but also your vulnerability of engaging in impulsive, risky behaviors, such as sexually risky practices. The other element that is very much relevant when discussing the effects of drugs and HIV is that the stress is a factor that actually triggers impulsiveness. It's sort of something that is common both as it relates to taking drugs. People take more drugs when they are under stress situations, and people that engage in sex behaviors as a way of escaping a very adverse circumstance may also engage in these behaviors when they are stressed. Amidst the challenges that we're facing as a country, because the use of drugs has continued to increase in the past 2 decades, an effect that has been exacerbated by COVID, and that therefore we're seeing more of a preeminence again of the contribution of drugs in the infection of HIV, but also of drugs in interfering with the outcomes of people that are being treated for their HIV condition. And the effects of drugs, because drugs can negatively impact the immune system in ways that can jeopardize the long-term effect, the long-term well-being of an individual that is HIV positive. The good news is that there is a lot of research that shows that there are evidence-based treatment interventions that improve the outcomes for people that have an addiction, and also that improve the outcomes of people that have an addiction and are HIV positive. In fact, the research shows that if we provide with treatment for individuals that of the addiction itself that are HIV positive, that significantly improves their outcomes as it relates to compliance, as it relates to viremia, as it relates to actually their overall health. And thus the importance highlighting that it is not justified not to provide with antiretroviral therapy to individuals who have substance use disorder on the basis of stigma and prejudice that they will not do as well. The data shows that's not the case, but also importantly, recognizing that treating the substance use disorder in an individual that is HIV positive is actually fundamental in order to improve their outcomes. As I look at what's going on in our country and that where the science has shown us, where there is evidence-based research that shows that interventions for treatment, interventions for syringe exchange programs actually are very beneficial. The issue that has been very frustrating is that even though that evidence is there, it is not being applied. And so to me, one of the key aspects of priority is how to implement these practices. And in order to do that, I think we have to face the recognition that substance use disorders, addictions are highly, highly stigmatized by society, but also specifically by the healthcare system. And as a result of that, people that could benefit for treatment, added to the stigmatization of individuals with HIV, are not being offered that treatment. And if we do not address that issue of stigmatization, we will continue to have a gap in terms of the failure to implement evidence-based practices. And we're now faced with COVID-19. And COVID-19, as I mentioned before, has made the problem of substance use disorders worse in our country. In 2021, as of September 2021, it was estimated that more than 90,000 people have died from overdoses. And if you look at the age ranges, you come to realize that among those that are 24 to 44 years of age, the mortality is as high or even higher than that produced by COVID-19. And that mortality, of course, is exacerbated in terms of the vulnerability to getting infected, not only if you have a substance use disorder, but if you are improperly treated for your HIV condition. So as we look at the lessons of COVID-19 pandemic, recognizing that it made us recognize that stigma should be one of the main targets that we need to change in order to improve the outcomes on individuals suffering from HIV in general, but importantly, also those that are suffering from HIV and a substance use disorder. And again, thanks for having me in this discussion.
Thank you very much, Dr. Volkov. You gave us a lot of information that I think a lot of us working in the field of HIV understand and get, particularly that stress sometimes makes people want to take more risk, the impact of drugs on the immune system, and this year, like you talked about, 90,000 deaths due to drug overdose during this year of COVID, which has put us all under tremendous stress. I was really excited to hear about the evidence-based treatment models, the focus on methamphetamines, which we know is that use is increasing in LGBTQ+ communities. But what can we do to ensure that we are incorporating services specific to drug use, particularly given this rise at this time? And you also mentioned at the beginning of the talk, because we've had probably about 40 or 50 people who've joined us since we started, but you also mentioned that many of our syringe services programs are under attack right now. And even though the science supports that we should be scaling these up, is there anything that community organizations and clinics doing this work could be doing more to sort of fill the gaps?
I think that, I'm going to tackle the last one because it is as frustrating as it can get. You don't need any more evidence to show how a simple intervention like syringe exchange programs actually is a very effective prevention for infectious diseases, not just HIV, but also hepatitis C. And we have history after history of examples where counties or countries have closed down on the syringe exchange programs to save money, has resulted in outbreaks. And this happens again and again and again, as if we couldn't learn from history. So I think that what we need to do is bring forward that data, not let it be forgotten, because the impact is so large. And you can predict that every time that you're closing this program, you're increasing significantly the risk of infections. And this is, as I say, I want to highlight it. It's not just for HIV. We're seeing it for hepatitis C. So how many more people need to get infected and with all of the costs associated with it or their deaths before people realize that here we have low-hanging interventions that should be implemented. And again, we have, and this is why forums like this one, where there is an opportunity to communicate back and forth, are so important. We cannot be silent. As it relates to the COVID pandemic, what we have faced, particularly the highest rates of mortality recorded in the states that we are monitoring very, very carefully, occur around, I would say, May, June, but it's still, they are still very high, and thus we've been trying to understand what are the drivers. And there are multiple factors that are driving the increased mortality. But importantly, one of them has been the difficulty in accessing treatment. As, for example, the healthcare systems were overwhelmed by COVID and the need to take care of these patients, then the resources that were available for people suffering from substance use disorder actually were no longer there. And that led them to be actually at much higher risk of overdoses. So lack of treatment was one of the factors that's likely to contribute, including lack of access to naloxone. Importantly, as it relates to HIV infection, for example, that lack of treatment and access to the healthcare system in conditions that are stigmatized and is likely to have contributed to, again, an exacerbation of the medical state of these patients. And all of it is, again, surrounded by, in a strange way, by stigma that then structure the system to prioritize certain medical conditions or certain patients more than other, as if they were more valuable, or as if it were justified more to do it for someone with a certain disease than someone with HIV or substance use disorder. I mean, that's a stigmatized, prejudiced perspective that is negatively affecting patients and communities. And that's where I think that COVID. So what can we do? Realize that we have to basically, and I've said it, as simply as this, we need to multitask. We cannot just say, okay, yes, we cannot stop focusing on COVID-19. Yet at the same time, we should be able to address the needs of these vulnerable, very vulnerable patients. And so it was quite reinforcing to see today that the CDC is recognizing substance use disorders as one of the conditions that is associated with higher risk for COVID-19 infection, but also at higher risk for negative outcomes. And this certainly becomes harder when someone has a comorbid medical condition, and is the case of HIV. So we need to put the resources necessary to support these patients.
Thank you very much. And so I'm going to ask you to stick around a little bit for us. We're going to pivot to Dr. Dieffenbach, but we're going to come back with some questions because Dr. Volkov, you've given us a lot to think about and some things to do. And I love how you said we need to bring forward the data to help us make some of these arguments around the importance of substance use disorder programs. And so we definitely want to come back to that, and also some of your points about stigma. And you, I think, very eloquently said what one of my public health colleagues said to me about COVID-19 and these issues of HIV. We need our public health systems to walk and chew gum at the same time. We must be treating both because there is this really important intersection that's impacting our work. So thank you for that. So now I'm going to turn to Dr. Dieffenbach. And Dr. Dieffenbach, I'm going to ask you to give us a brief update on the important work that the Cfars have been doing to address the HIV epidemic.
So I want to start, Harold, by first recognizing your leadership on the Ending the HIV Epidemic, a plan for the United States, and what we have been collectively doing as HHS optives to really try to come together to help end the HIV epidemic in the United States. And really what we have been seeking to do is, through partnerships with community and with other HHS partners, to find better ways of diagnosing, treating, preventing, and responding to the emerging questions that we see associated with HIV. Again, all politics are local, and that's why we really want to stress the engagement with partners at HRSA and at SAMHSA, so that when we work with the health department, what we find as academics through Cfars is directly applicable and implementable in communities where we need to improve diagnosis, treatment, prevention, and response.
So thank you very much for that. Can you highlight a few of the innovative projects that have been highlighted during the recent Cfar meeting?
Sure, there's been, again, so we can pick some on the idea of ways of diagnosing. Can we provide ways of providing home test kits that are then linked better into care? So that when somebody tests positive at a home test, how can they get into care as quickly as possible? I think that one of the best examples for impact is expanding same-day treatment in a variety of settings. Usually it's within a very large clinic, but are there better ways and more unique ways to expand same day start, so that somebody is diagnosed with HIV, they leave the clinic with a pill in their body and a prescription, so that they have had the possibility of realizing that therapy is a lifeline to a quality of life that they thought might be gone.
So thank you for that. I know that I attended the Cfar conference, and not only were the presenters great, but also the way you had the poster sessions in a virtual space. It almost felt like I had the opportunity to walk from booth to look at the different posters, and each one was sort of a snippet of 1 or 2 minutes that included slides, and you got a good snapshot of that. So where can people go to find more information about the Cfar research and some of the pieces that are out there?
Well, the best place to get all that information is on hiv.gov. That is where most of the data gets stored. It's available, it's routine. At the same time, if you want to take a deeper dive into the HIV research, the slides from the Conference for Retroviruses and Opportunistic Infection, the CROI 2021, are now available, as well as the HIV prevention, HIV-R4P, Research for Prevention, is all available. These are incredible resources in terms of the level of and quality of the research that's being done, and the level of information that's available.
So can you also tell us about the next steps in implementation science research that you all are working on? And I'd also encourage, I know there's been a lot of talk about sort of the social determinants of health and what we can do to address those. Is the implementation research tilting in that direction as well?
I think it has to, Harold. It has to tilt in that direction. I want to come back to a point that that Nora made about stigma. And I think that as we look across diagnosis, treat, prevent, and respond, being able to tackle stigma at many, many levels is going to be an essential component of what we do to also then address the determinants of health. So I think that it is essential that we move forward in this way. So we have a number of initiatives that are in the process of being developed and brought forward that will allow for the next phase. So what we have been running through the Cfar program are a series of pilots where we're getting some very interesting and tantalizing preliminary data. Can we now take some of these to a different scale where they're implemented a little more broadly to see if they really can have the type of impact that we need in order to help us achieve the goals of ending the HIV epidemic.
Thank you. So before we turn to our Q&A portion, I'd like to ask you both. We've made a lot of progress in the last decades with regard to HIV research, and we've got a lot of toolkits that have been developed for both prevention and the treatment options. What are some of the gaps that still remain so that we can better reach people who not only use injection drugs, but all drugs?
Well, I would start by saying, actually, and I'm glad you brought up the question of the racial disparities, because I was going to do it otherwise. And I think that as we're discussing that the discrimination against people with substance use disorder and with HIV, it's even worse if you are a Black American or come from an underrepresented group. And therefore, the consequences can be felt, those consequences of discrimination can be felt, for example, in the fact that if you have a opioid addiction, and we have very effective medications for their treatment that protect you from overdosing and dying, if you are African American, you're basically going to be prescribed those medications in average 5 years later than if you were white. And if you look at it from the perspective of what Carl was discussing about how important it is to initiate antiretroviral therapy as soon as possible once you have a positive diagnosis of HIV, it's also been very frustrating to see that despite the evidence being so strong and that you have substance use disorder, you respond to antiretrovirals as effectively as if you didn't. Clinicians out there are not prescribing them as fast as they should, and we still have a large gap to change those practices, and that just reflects ultimately prejudices that clinicians have towards treating people with substance use disorders that in many instances says, I'm not going to give this treatment unless the person stops taking drugs, without realizing that there is benefit and you can work both of these problems in an integrated fashion. So this is, again, one of our, from the research perspective, is what are the models that can change that stigma and that can maximize the efficacy. And in this respect, for example, the integrated models of care that provide access to treatment for substance use disorders in infectious disease clinics become very important. Another area that has generated a lot of interest because of its potential impact is, of course, research of implementation and services in criminal justice settings. And this is because there is an overrepresentation of individuals with substance use disorders or who are HIV that actually pass through the jail or prison systems in our country. And this is an opportunity of actually ensuring that these individuals are properly screened and, if positive, treated. And thereupon, a huge gap that we currently have in these justice settings is when they are released back into the community, many of these individuals that had been initiated in antiretroviral therapy or in medications for their substance use disorders basically are dropped because they have no insurance. Many of the states basically revoke Medicaid if the person ends up in the justice settings. So right now with the COVID pandemic, that has led some of the states, force them into changing those practices. Not, I wish it had happened across all of the country, but at least for those that have done it, it gives us an opportunity to see how these models of care, rather than being punitive. If you've taken drugs and you end up in prison, you lose your insurance, recognizing how damaging that is. And as you were discussing the issue of racial disparities, we need to recognize that there is an over-representation of Black Americans in justice settings. So this just exacerbates the problem. So these are some of the issues that I would call in terms of structural factors that we have in our society, on the way that we treat people with addiction, on the way that we discriminate people from minority groups. And we also discriminate individuals with HIV that are perpetuating worse outcomes.
Thank you very much, Dr. Volkov. That's really helpful. And you mentioned several, I think, the structural factors and the systemic factors that also get in the way of care and treatment and effective prevention implementation. As we open this up for questions, I think one of the things that has come up, and you started us down, well, maybe I started us down this path and you continue to follow Dr. Volkov, but I'm gonna throw this to Dr. Dieffenbach as well. So we definitely have heard a lot about stigma and discrimination and sort of the dual discrimination that goes on between minority populations and substance use disorder. When we think about the Cfars and a lot of their work, What are they finding in terms of structural or systemic barriers? And how does that get incorporated into the research agenda?
That's a really important question. So there are some very significant systemic barriers. Let's focus on pre-exposure prophylaxis, or PrEP, for just a moment as an example. Nora raised the issue about insurance. Insurance is really a major barrier, particularly for the low-cost plans, in terms of what can be charged for somebody with who wants to take PrEP. Additionally, the department has a program, a PrEP for All program, but it requires the person not have insurance. So there's still a donut hole there that we have to be able to fill. And there's something about starting PrEP that has the need for social support. And so if you already are suffering from feeling stigmatized, starting a medication like that just adds to the burden. The other type of structural barrier we see is housing. Unstable housing, food insecurity are also major issues as we go forward. And if you think about what we're seeing in the coronavirus pandemic, the unstable housing component has just exploded, with people not being able to afford rents, with the threat of eviction. It remains a major challenge. But one of the strengths of the EHE program is that we have brought in people from HUD and other parts of the government to help us to truly understand what we can do to address these kinds of barriers.
Both of you have talked about and mentioned the need for sort of integrated services to be able to address some of these intersectional issues. And we know that within government, often we have these sort of siloed funding streams that sort of cause sometimes what I call the one silver bullet approach for some of our programming. And in the National Strategic Plan, we also call for sort of scaling up and a syndemic approach. And, you know, as you all are the researchers, do you have any advice for those of us that are either at the federal level or at the local and state level about sort of rethinking our approach to how we sort of provide funding? Do we need to be doing more braided funding streams or blended funding streams to really and truly eliminate some of the barriers that we might be creating as we sort of think about, you know, we've got a housing program over here and public health over here, and then we've got a substance use division somewhere else within the public health department. They're not working with viral hepatitis and HIV. What advice do you have for us about sort of really this integrated approach, which we all, I think, agree is needed? Are there better ways to do it?
Yeah, no, I was smiling about it because it was music to my brain. I think that the notion of advice number one is you want policymakers to actually pay attention to the science. And I think that we always assume, yes, the science is going to guide policy, but that's absolutely not necessarily the case. And so that would be advice number one. But advice number two, to me, it strikes me that this is an opportunity to actually evaluate. And my understanding is that CMS had initiated a project that aimed to look at whether if they funded in integrated fashion or very novel approaches, for example, that would consider funding for homes for people that were homeless, which in turn will improve the likelihood that they remain in treatment, both for substance use disorder and for HIV, whether if CMS funded for that, that will result in better outcomes. And I think it does beg the question for us to be critical on the way that we put funds that are so very separated, and as a result of that, don't maximize the likelihood of being effective. We struggle a lot with this issue because clearly, and I'm glad Carl brought it up, the issue of homelessness and food insecurity, particularly homelessness, is the number one factor that patients tells you is the reason why they cannot stay in treatment. As simple as that. So I can have all of these very fancy, powerful tools for treatment, but if I don't provide a support system that will allow those patients to take advantage of it, it has no impact at the population level. So bringing forward models that consider a more integrated fashion of funding the needs that are required for the treatment to be available and sustained, and provide the economic advantages in terms of cost effectiveness that those models bring. I think that that information would help very much guide better how to fund streams of funding, which, as you said, have been very, very siloed.
Dr. Dieffenbach, anything to add to that one?
Yeah, I think, you know, for the last many years, we've had a national HIV strategy. And the purpose of that strategy is to streamline and harmonize and to bring the different components of the federal system together to work in partnership rather than across purposes. And I think we really need to re-energize that process as we go forward so that we're not tripping each other up. And I think that, you know, what happens on the ground at the health department is really critical. So start with the funding for health departments. So there is a sense of customer service in that environment as we go forward. So it's not, and part of the challenge that health departments and we all face is the 17,000 different streams of funding we have to deal with. So to the extent that we can streamline, standardize, systematize, and then also keep the client's best interest at heart first and foremost. Provide clear, concise information that is understandable by members of the community so they can act in their own best interest.
Yeah. So one of the questions in the chat was about the free program for PrEP that you mentioned, Dr. Dieffenbach. I'm not sure if that was the HHS PrEP program, which is the registered PrEP program.
That's the one I meant.
Okay. And again, if you need more information on that, you can get that on hiv.gov. And that is for individuals who lack prescription drug coverage. But there are other ways to access PrEP medications. So don't let cost be a barrier to figuring this out, especially for those that are at risk. There are programs that can assist. We've also provided funding to our community health centers. The health center programs also have access to medications as well, and our public health departments as well. So definitely check hiv.gov for more details on how you can access the PrEP programs.
One other point there, Harold, we really need to, that also came up in the chat, of medical mistrust and making sure that we are providing the clearest answers to questions to people with concerns. Because we see this, it doesn't matter where we are, whether we're dealing with vaccine hesitancy or PrEP hesitancy or starting therapy, HIV therapy. You know, clear information and making sure that physicians and nurse practitioners and the people on the front lines are armed with the facts so that they can allay fears, not sugarcoat it, but to really make sure that we get people the information that they need.
And one of the things that I love about the Cfars and the work that's happening at NIH is that you all are really doing research that looks at the entire HIV prevention toolbox. So we've talked some on this in this session about syringe services programs. We've talked about PrEP, but there's also some great work that's happening with behavior change and modification as well in both programs. And so I think the researchers are really looking at how do we provide this range of prevention options to individuals, and really how we will scale that up. There's also, I think, exciting work that's happening as we think about the long-acting injectables and its impact. So I think with more tools coming to the toolbox, I think we'll be able, and figuring out how do we implement them in the clinical setting so that there's more patient choice about sort of what's right for them. And I think you talked about this too, Carl, sort of being patient-centered. The work on the front lines is really difficult and challenging. COVID-19 has also made our first year of EHE implementation also challenging. Both of you are extremely passionate about this work. So are there any sort of words of inspiration or anything that you want to say to the community that's out there on the front lines that is trying to implement these programs in really challenging times, both with laws and regulations against syringe services programs, as well as trying to meet the needs on the front line, which are multidimensional?
Yeah, I'm in my perspective, I think that there are many challenges, and COVID pandemic has stretched our capacity as a society to respond to probably the largest challenge that we've ever seen. Yet at the same time, it has emerged into, to me, some of the most amazing accomplishments. I mean, the development of the vaccine for COVID, the vaccines for COVID that are so effective, and then their deployment such that now the majority of adults in the United States are vaccinated. That is all inspiring. And it was possible because, of course, of innovation, creativity, but importantly, partnerships and the recognition that we have a common mission. And that was, I think, very clearly understood. As we are looking forward in terms of the challenges that we face with stigma, I think that recognizing that when you can bring forward a mission that everybody understands and realizes that we can solve, that I think can energize very much collaborations and partnerships like we have seen during the COVID pandemic. So while it has been very difficult at many levels, it has also been extraordinary to see how science and the ability of people to come together and organizations to solve a problem, that also has been very, very inspiring. And I think taking that inspiration and saying, let's move it towards this mission of addressing, we have still to address the HIV epidemic, and we need to address it with no stigma, to integrate it so that we don't discriminate if someone has a substance use disorder or they come from an underrepresented group or a hard to reach population. That has basically, I think we have, again, so much evidence about how negative stigma and discrimination is on outcomes that one would hope, as we have learned with COVID, that we need to get rid of it.
So I think for us, being able to capture the learnings that we have from the Cfars and the AIDS research centers, and put them in a place that is accessible and understandable, not just to the academics, not just to the health departments, but to community as well, is making a big difference. And that's one of the things that NIH has been pioneering, is this notion of creating these hubs where the information is routinely available. And again, through accessing HIV.gov, we can make that kind of activity available. And over time, as we go through these cycles of improvement, understanding, the tools will get better. And then they can be then scaled to health departments of different levels of funding. I mean, not all health departments around the country have a degree of equivalency. Some are very well funded for a variety of reasons. Others don't have the resources they need. So in many ways, the tools need to be tailored. Again, all politics are local. As I said before, we have to be able to have something that works in the rural South as well as works in San Francisco or New York. There has to be a set of tools that are tailored to the specific jurisdiction.
So as we, thank you both. We have had, I think, a great discussion today. And I want to thank you both for being here and for the work that you all and your teams are doing to really look at these issues and try to problem solve for our communities. And thank you for inspiring us and really getting us to think about how we build on the success of COVID-19 and move forward to end the HIV epidemic, tackling some of the issues that you mentioned about racism and our systems that don't collaborate often well. You've challenged us to look at some of those barriers and to use the data to make the arguments about the effectiveness of these interventions, and to be patient-centered, and to also realize that not all of our jurisdictions are equal. And as we have these conversations about equity, we need to keep this in mind. So thank you both, and thank you all for joining us today. Please check hiv.gov for more information so you can stay up to date on the Ending the HIV Epidemic Initiative and also our Live with Leadership conversations. So thanks again, everyone.
Thanks, Harold.
Thank you all.
Bye-bye.